Welcome to the first Knowledge into Practice module that I've ever created. The idea behind these modules is they're programmed exercises that help you practice clinical skills that you've learned and really incorporate them with your clients. We're all creatures of habit, me included, and it's very difficult to actually change how we work with people. So these Knowledge into Practice modules are designed to help you change your clinical behaviors and smooth out some rough edges and be more effective with your clients ultimately. This Knowledge into Practice module follows a clinical process whereby you meet somebody and you do this whole case staking thing where you find out information about them. And then, depending on what they tell you, you conduct a physical assessment that's designed to identify the key issues or impairments that are at play in your client's body. And then we try to rank those impairments according to how important they are to that person at that moment and what their experience is. So you blend those impairments with what your client would like to achieve in their care and their particular biology into a treatment plan. And that treatment plan addresses those key impairments, usually in a hierarchical or ranked way of what things are more important and so on. And home care is prescribed to the client that supports them moving out of being compromised by these problems or impairments. We also track outcome measures, which are things either in the client's experience of their pain or function that they'd like to change, or objective measures, which are things that the massage therapist measures, which could be sensitivity to palpation or absolute strength during a resisted test or things like that. Presence of myofascial trigger points, things like those are objective measures. The history-taking phase of the clinical process is it's a big deal, eh? You're really trying to get a handle on who this person is, what their experience is in their body, and what they want to do about it. Beyond all that, you're trying to get really precise information about their problem or their issue that they want help with. In terms of supraspinatus issues, the following factors tend to be important. So younger clients up to late 20s, early 30s are often more prone to tendinitis issues, inflammation of the tendon. But then middle-aged clients and beyond are much more prone to tendinosis issues, which are breakdown issues of the tendon losing its strength and parts of the tendon degenerating and turning into softer, less functional tissues. So it's important, if we can figure out whether someone has got inflammation of a structure that is basically competent, or they've got breakdown of a tendon that is really weak and incompetent and leading to all sorts of issues. The location of your client's pain is a big deal. The supraspinatus muscle itself often has trigger points that refer to the lateral aspect of the shoulder in terms of the middle deltoid region, and often as well to the lateral epicondyle. Sometimes these trigger points can be mistaken for tennis elbow. But of course, if you create these sensations through palpation and provocation of trigger points in the supraspinatus, then the supraspinatus is an issue. Clients who report that in certain positions they get feelings of pinching or pressure inside the shoulder joint often have impingement, which is compression of the supraspinatus tendon as it passes underneath the acromion, or the arch of connective tissue connecting the acromion to the coracoid process of the scapula. And sometimes clients will point directly to the greater tubercle and touch it as being the worst place of soreness or pain in their shoulder, and that should also get you thinking of the supraspinatus. In terms of history, sometimes people report some kind of trauma or overload. They fell in such a way they tried to protect themselves by abducting their shoulder and then having that overpowered as they fell onto that outstretched arm. usually to the side. Sometimes they'll report maybe they had some really heavy luggage that they carried on a trip, and they didn't get much sleep, and they had to run through the airport, and they're dragging this thing behind them. Other people report overhead activities, so you've got swimmers, for example, and pitchers, baseball pitchers, javelin throwers, shot putters, and so on, often have some impingement overload of the supraspinatus tendon. The length of time that the person has had their symptoms is often very important as well. So people who've had shoulder pain in this way for 2 to 3 weeks could have an inflammation, a tendinitis, which means the tendon is of normal structure, it's just inflamed because it got overstressed. Whereas people who have symptoms for a month, especially 2, 3 months and longer, they almost always have tendinosis or breakdown of the tendon, which cannot be fixed through massage therapy, but can often be restored through precise exercise prescription. Of course, even those people with tendinosis have tons of myofascial issues and joint movement issues that need to be addressed. So it's not just an exercise prescription, but exercise prescription will be a big factor in helping them. So those are the kinds of things that you tend to think about when you hear them. When you hear them, you think about maybe this person has a supraspinatus problem. This is in addition to your regular health history taking, where you screen for medical pathologies and use of medications and all that other stuff. It's common for people to have had care by other massage therapists, chiropractors, and physios, and so on. So it's important to identify the kind of care they've had, the elements of that care that were helpful, and the kinds of problems that remain after that care was completed, so that we don't have to repeat a lot of what other people have done, but we can address the elements that might not have been addressed by the other healthcare providers.